Okay, I hope my the right screen is showing.
Yes, we can see
Um,
it.
Great, thank you. So, hello everyone, and thank you for joining me. I'm Hilla. I'm an internist at the Koret School of Veterinary Medicine in Israel, and I'm going to present today this study. It's called Prevalence of Acute Kidney Injury and Outcome in Cats Treated as Inpatients versus Outpatients Following Lily Exposure. This paper comes from Penn University, and it was published in JAVMA this last February. So just before I begin, I want to apologize in advance for two types of potential alerts. One is my baby waking up, but for this one I have a potentially good solution. And the other one is rocket alarm, which we have every few days here. So hopefully we don't get one at all, but especially not during the presentation. If it does occur, I'll have to leave the meeting for at least 10 minutes. Okay, so Lilium species are known to be nephrotoxic in cats. Lily toxicity causes clinical signs including vomiting and hypersalivation, usually within hours, and AKI, which typically develops within 24 hours. The specific toxin, however, is not well characterized. It is known that it is water soluble and that it is found in all parts of the plant, but the pharmacodynamics and pharmacokinetics of the toxin are not known. And due to this gap of knowledge, evidence-based recommendations for treatment are not available. So the standard of care is basically based on a small observational study, also coming from Penn University. This study was published in 2013 and included 25 cats that were treated for Lily toxicity with IV fluids. Only 2 cats developed AKI, and all of the cats survived. So the treatment recommendation coming from this study or based on this study include GI decontamination, IV fluids for 48 hours, and monitoring with daily assessment of kidney function. Some owners cannot or won't hospitalize their cat to be treated, and some cats are treated therefore as an outpatient, and the outpatient management, or at least the suggested outpatient management, includes GI contamination and then daily subcutaneous fluids and monitoring of kidney function daily. However, the prevalence of AKI in cats that are treated as outpatients after the exposure is unknown. And therefore, the aims of this study were to compare the outcomes and prevalence of AKI in cats with known or suspected Lily exposures that were treated as inpatients with IV fluids or as outpatients. And a secondary aim was to investigate for factors associated with the development of AKI. And the author hypothesized that the outpatient group would be associated with higher prevalence of AKI and worse outcome as compared with the inpatient group. So this was a retrospective study and included medical records of cats that presented to the University Teaching Hospital between 2011 and 2024. And they included cats that presented not more than 48 hours after the Lily exposure. Cats in which the time of presentation from the exposure was documented. Cats that had their creatinine at presentation documented, the baseline creatinine, and then at least 2 creatinine measurements in 2 different time points available after presentation. And they included cats with non-lily exposure, which was defined as cats that were witnessed ingesting or vomiting pieces of the lily, or if they chewed on a flower or a leaf, and or if they had pollen on their body. And they also included cats with suspected exposure, and this was defined as being in the same room with lilies. And I think this is something worth highlighting, that in fact the population of cats in this study in both groups included cats that were actually or potentially not exposed to lilies. So we need to take that in mind when we look at the results of this study. They did exclude cats that presented more than 48 hours since the exposure. If they were hospitalized at other facility prior to presentation, if they're exposed to a non-nephrotoxic lily, if they did not have a baseline creatinine or at least 2 more follow-up measurements, and if they had other comorbidities. And then they retrieved a lot of data from the files, including the date, the signalment, the lily exposure, whether it was known or suspected, the lily species, the maximal time from the exposure to presentation, the initial decontamination treatments, whether emesis was induced and if it was successful, if the lilies were seen in the vomitus, if they had a gastric lavage or received activated charcoal. And then for the inpatient groups, they documented the duration of hospitalization and the maximum rate of IV fluids. And for the outpatient groups, the dose of subcutaneous fluids if administered. And then for both groups, they documented the creatinine and AKI grade at presentation, and then the follow-up creatinine during the first 24 hours, and then 24 to 48 hours, and 48 to 2 weeks. If AKI developed at any time point, yes or no, if AKI grade was static or improved, and what was the outcome. And then for the statistical analysis, so for the sample size, they used the proportion of cats with AKI that was from the previous study I mentioned. And then they hypothesized that in order to show a significantly clinical difference, there should be a 30% more AKI, like a difference of 30% between the groups. So they assumed 39% of AKI in the outpatient group would be clinically significant. And according to these hypotheses, they calculated that they would need 90 inpatient cats and 15 outpatient cats. And the other statistical tests were just the standard statistical analysis. So for the study findings, 179 cats presented for lily exposure. Of them, 67 cats were excluded, most of them due to lack of follow-up creatinine values. 14 cats were excluded because they presented more than 48 hours after the exposure. Cats were also excluded for missing or incomplete medical records, for lack of baseline creatinine values, and for other comorbidities, including iatrogenic uroabdomen, pancreatitis, and suspected triaditis. And 1 cat was excluded because it was exposed to a non-nephrotoxic lily. So eventually 112 cats were included, 96, which is 86% in the inpatient group, and 16 in the outpatient. The median age of all cats was 3.4 years. The age and the sex were both non-significantly different between the inpatient and outpatient groups. The type of Lily was known in about half of the cats. The maximum time from Lily exposure to presentation was not significantly different between the two groups, although, as you can see, it was relatively shorter in the inpatient group, but again, not statistically significant. There were significantly more cats with known exposures in the inpatient group compared with the outpatient group. So this again is something which I think is worth highlighting, because not only cats with suspected or uncertain exposure were included in the study, most of the, or not most, but about a half of the outpatient group had a suspected exposure, and most of the inpatient group was known to be exposed. So again, this is kind of confounding the results. Regarding treatments, then the inpatient group, in the inpatient group, about a third of the cats they attempted emesis, and it was successful in about 2/3 of them, and in almost half of them, lilies were seen in the vomit. And then in the outpatient group, emesis was attempted in 2 cats. It was successful in 1 cat, and in this 1 cat, the lily was present in the vomit. Activated charcoal was given to about a third of the cats in the IP group and to 2 cats in the outpatient group. Fluid therapy, so in the outpatient group, 13 cats, which is a bit more than 80%, received subcutaneous fluids in a median dose of 15 mL per kilogram. And in the inpatient group, the hospitalization median duration was 50 hours, and then the median maximum IV fluid rate was 2 mL per kilogram per hour. And in this table, we can see all the variables I was discussing in the inpatient group and in the outpatient group. So all variables of signalment and the treatment types were non-significantly different between groups, except for the type of exposure, which I mentioned before. So most of the cats in the inpatient group had a known exposure, while about a half of the cats in the outpatient group had a suspected exposure. So, and this was significantly different between the groups. The baseline creatinine of each of the groups was 1.3 mg per deciliter, and this was not statistically different between the groups. AKI at any time point, so in the inpatient cats and in the outpatient cats, about 47 and 44% of the cats had AKI at any time point. And in the inpatient groups, most of the cats had AKI grade 2 and 17 cats had AKI grade 1, and only 1 cat had AKI grade 3, while no cats had AKI grade 4. And pretty similarly, in the outpatient group, 3 cats had AKI grade 1, 4 cats had AKI grade 2, and none of the cats had either AKI grade 3 or 4. 60% of the inpatients and 57% of the outpatients had a static or improved AKI grade at follow-up. There was no association of treatment group and the development of AKI at any time point. Again, I remind you the confounder we were talking about. So this is something that we need to remember throughout the results. There was no association between any of the other parameters, including treatments, with AKI at any time point. There was a significant association between the treatment group and the outcome. So 100% of the inpatient cats survived, and 88% of the outpatient cats survived. This basically means that 2 cats in the outpatient group did not survive. However, these 2 cats were euthanized, and they were euthanized with creatinine values of 1.8. Both had 1.8 milligrams per deciliter. One of them during the first 24 hours, and then the second one had a 1.8 creatinine during the second day. So the reason for their euthanasia was not severe AKI. It was basically unknown. It was based on clinical signs. So again, there was like a significant difference between the outcome in both groups, but we cannot say it is due to AKI. So for the discussion, the authors discuss having no increased prevalence of AKI in the outpatient group, and they say this is likely due to the increased AKI prevalence in both groups, which was 40-something%, compared with the previous study in which only 9% of the cats had a AKI. They explain this is probably due to many AKI grade 1 diagnoses, which was probably less something which was less highlighted before, and today with the new IRIS guidelines, AKI grade 1 is more readily diagnosed. Also, they have a larger cohort. They also discuss that in this population they've seen lower AKI grades than, or just low AKI grades, basically excluding 1 cat with AKI grade 3, all cats had AKI grade 1 or 2. So maybe liver toxicity causes low prevalence of severe AKI. They had a 100% survival in the inpatient group, and they explained that due to the 14 cats that were excluded due to late presentation, or because they were hospitalized elsewhere, this might have affected the result and the survival rates. And they explained that the decision to exclude these cats was because they did not want the influence of delayed treatment, and because specific treatment may not have been recommended for cats without evidence of AKI after 48 hours from exposure, and also because treatment of established AKI may have differed from what is provided at their institution, and they wanted to avoid all these effects. But ultimately, I think this created this selection bias, which I understand every one of the points they raise here, and it could have caused a different type of selection bias, but I think 100% survival probably does not reflect what we see in reality in cats with liver toxicity. Regarding fluids, there was no difference between IV and subcutaneous administration in preventing AKI, but they do say that this study was underpowered to detect treatment effects. And I will remind again that the outpatient group included more cats with suspected and unknown exposure, so this also might have affected the results. They do acknowledge here the known exposure, that known exposure was more prevalent in the inpatients, and they assume that this lower index of suspicion for exposure actually caused owners and maybe clinicians to elect the outpatient management. And this is the reason for the difference between the groups. Gastric decontamination was not associated with the development of an AKI, so it may have little effect on the prevalence of AKI and outcome. And the limitations they acknowledge in their discussion is that they may have possible overdiagnosis of grade 1 AKI. This could be attributed to day-to-day variability of creatinine, because their definition for grade 1 AKI is based on the IRIS guidelines, so an increase of 0.3 milligrams per deciliter, which could be just a result of day-to-day variability, could have caused them misdiagnosis or overdiagnosis of AKI grade 1. Also, the use of different analyzers in the follow-up measurements. Some cats were followed up in private clinics, and then they got the results afterwards. So different analyzers could also be contributing to this change in maybe over and also maybe under diagnosis of AKI. Also, there was no follow-up after 2 weeks, so recovery of cats with AKI was not evaluated, and I think this is something that could have been valuable, and because cats that did sustain AKI and were exposed to lilies, and then they could maybe, if we had this data about how long it takes to recover and how many cats actually did recover, could have contributed. So maybe for another follow-up study. They did not have urinalysis available for many of the cats, and this was something they were mentioning. Again, cats with suspected exposure were included. So I talked about that enough, I think. And then this was a tertiary referral hospital, which limited the number of cats in the outpatient group, and also maybe represent a very specific type of population. And there was no randomization. So the cat and client and clinician related factors may have influenced the treatment groups and the outcome. So they concluded that a higher prevalence of AKI in both groups occurred, relatively at least to what was previously reported. And the cats that did sustain AKI, it was of low grades. And they had an excellent survival rates, which unfortunately is something that I do not personally see with lily intoxication. I mean, obviously there are cats that are coming in and they do sustain low grade AKI and recover, but we do see cats with higher grades of AKI not recovering. And that's all I have for the paper. So if anyone have any comments or questions, I'll be happy to answer. And I also wanted to raise some questions if anyone wants to share what their experience. Do you hospitalize or recommend to hospitalize every cat with suspected or known lily exposure? Do you do GI decontamination? Do you see other clinical manifestation of lily intoxication? I will say that I think, I mean, at least the cats with lily exposure that we see, they usually come in at the beginning, they're feeling pretty well, But then, and even if they don't have severe AKI, some of them can develop like really severe clinical signs compatible with pancreatitis, which I think really affects their outcomes sometimes. So I don't know if it's something that is more common in our geographical area and if anyone else sees that as well. And lastly, I will say that Dr. Ji-Woong is conducting a multi-center study of cats that sustained AKI following glial toxicity and managed with hemodialysis. So if you have cases that you want to share and you want to be a part of this multi-center studies, then email Dr. Ji-Woong. So unless anyone else has anything to say, I will thank you for joining me and have a great rest of your day.
Hilla, thank you for that. I just want to say we also have recognized a pretty high prevalence of pancreatitis in these cats. I think most of the cats we've seen have been more advanced grades of AKI than documented in this study, but that certainly seems to be a feature from our perspective.
Yeah, I agree. I think also going over some files lately that we want to include in Ji-Woong's study, definitely maybe all of the cats that, at least the ones that were managed with hemodialysis had pretty severe pancreatitis. And sometimes it's hard to say whether it is just clinical signs that are secondary to the severe AKI, but I think these were very compelling signs. So another thing to consider when treating these cats. Okay, thank you very much, everyone.
Thanks. Have a great afternoon.
Thank you,
Thank
Hilla.
you.
Thank you.